Hello and welcome to another episode of the Crisis Response Podcast. Today, I am joined by Neil van der Merwe from ComMed EMS in Johannesburg, South Africa. Welcome, Neil. It's a real pleasure to have you on the show today.
Thank you, Jason. Great to join you on the show.
Excellent. So please tell us a little bit about ComMed EMS, what you do, where you operate, the services you provide.
Certainly. So ComMed is based in Johannesburg, South Africa. We are a non-profit NPO organization. We are all volunteers that are part of the organization. We all have other jobs. Some of us work for private EMS services, as well as in other industries. And we've essentially been running for about 3 years now. We started around about the beginning of COVID. We saw that there was a need for people who essentially did not have private medical aid or could not afford private medical response services, and were waiting for extended periods of time to get things as simple as oxygen. And in many cases, people were dying because they just could not get either a service or they just could not afford to get the emergency support that they required. So we started out at that point providing oxygen to people, and it kind of grew from there. At this point, we operate in what's known as Region C, which is the part. It's part of Johannesburg. It's areas such as Florida and an area called Roodepoort. It's a fairly large area. We are most active at night. Mostly during the day, we're either on our own shifts or we are in our paying jobs. So, if we have medics available during the day, we will assist. Otherwise, we will hand calls over to a different service. But at night, we will essentially support those services. We don't run ambulances, so we are not an ambulance service. We are just a response service. And really, we fill that gap between someone calling for a response service and an ambulance actually getting there, which in some cases can be 3 or 4 hours later. It's fine if you have medical aid and if you can afford to go to private hospitals or make use of private services, because generally those services are very quick, and within 10, 15 minutes you would have an ambulance at your door. If you are unfortunate enough to not be able to afford that, though, you would rely on either a private service supporting if they were available, or you would need to rely on government services. The government services, while I think they are doing a great job, they are just overwhelmed by sheer volume. And there's a good chance that in an emergency, something serious, and you are going to wait hours, unfortunately, for an ambulance or a medic to get to you. So we fill that gap. We go out, stabilize, support you, essentially keep you alive until an ambulance arrives, hand you over to an ambulance to be transported to a facility.
That's really fascinating. It's a very different state of emergency medical services than probably a lot of our listeners are used to. So Johannesburg is a very, very large and expansive city, as I understand it, several million population, but there's the chance that people could be waiting for up to hours, you said, for an ambulance to arrive. And that's the government services, right? Who are, as you said, doing their best, but are overwhelmed. So what level of care? It sounds like you're providing advanced life support, or is it BLS? What level of care do you provide?
So in South Africa, I think our levels are probably slightly different to many parts of the world. We have many first responders out there that are really just first aiders. Then we have BLS, basic life support, intermediate life support, and advanced life support. So as a service, we provide mostly an intermediate life support service. We do have some advanced life support paramedics that do volunteer with us as well, and do provide services. But for the most part, we provide intermediate life support services, and that's usually sufficient, for our sort of purposes. We generally have hospitals that are fairly close to where we are, so travel times would be 15, maybe 20 minutes. So we can support and sustain life until such time as we can actually get you to a hospital, or until a service can get you to a hospital.
And so what falls under an intermediate life support scope? Is it, you spoke about oxygen, obviously, though that's basic? Does it include IVs, medication administration?
Absolutely. Absolutely. So there are, it most certainly includes IVs. There are procedures such as chest decompressions and, needle cracks and so forth that all form part of it. There are a number of drugs that fall under that scope, corticosteroids, adrenaline, and so forth. So it's a fairly well-developed scope. And I think, from a standards perspective, our intermediate life support medics are generally people that have been on the road for quite some time. They've built up the hours, they've built up the experience, and we will generally be able to get onto scene to support, and if necessary, we will request advanced life support, and then either together with the ambulance service that arrives, we will transport to a hospital, or we will simply hand over to that service to transport to hospital.
So needle decompression, needle cric, as an American, to me, that sounds very advanced, but you're calling that intermediate life support. What does advanced life support consist of in South Africa?
So advanced life support really has a significant drug scope. We've also quite recently changed the whole structure in South Africa. South Africa used to, I'll say, grow our medics or grow our paramedics through short courses. And in between the short courses, there was a certain number of hours that would need to be completed and so forth. That changed a couple of years ago, where it's now essentially a university degree is largely the only way to get to be an advanced life support paramedic, or as we call them, ECPs, emergency care practitioners. And they have a significant scope. Anything from, they can do IC drains, for example, chest drains. Their medication scope is goes right up to fentanyl and so forth. So it really just depends on the situation. I think as the universities are starting to put out the sort of new style paramedics, at this point, I think the numbers are still fairly low, but over time we would expect to see a lot more of these individuals on the road as well. And they are really the gold standard paramedics in terms of being able to support you and keep you alive.
It's fascinating. What, if you know the answer to this, is what is the philosophy driving this, right? I mean, in the US, to what I can speak about, I can imagine a couple other professional groups that are not so interested in seeing paramedics get, such a wide scope of training. And they would rather see that stay with, nurses, physician's assistants, your traditional clinical levels of care and training. Why is it that South Africa is doing this, giving such advanced training to non-physicians, non-nurses? Do you happen to know?
So I think part of it is really due to the country and the environment. Historically, I think we have not had enough hospitals. We have a lot of rural areas, for example, that are not necessarily close to hospitals. So, they would require either flights in or out, or long transfer times. And really, in those types of situations, you want someone that can go out to that rural environment and be able to support to the necessary level. And of course, doctors also, there's been shortages in the past. So really the doctors and the advanced life support work very closely together. In fact, I would say that the medical profession in general work very closely with the pre-hospital side, and it's I think the one can't do it without the other. It's the types of incidents that we see, unfortunately, across the country. We have a very high incidence of motor vehicle accidents. There are a lot of violent incidents, shooting, stabbings, those sorts of things, and unfortunately, we are on the road and we are able to support in those cases. And if the pre-hospital teams are not available, it's a problem. You're just not going to get the necessary coverage to support those folk.
That makes a lot of sense. Yeah, I mean, obviously here in the United States, we have quite a bit of rural area too. but getting advanced or expanded scopes of practice for paramedics is a uphill battle for sure, though it's definitely changing. So, you mentioned just now motor vehicle collisions and stabbings and shootings. What types of calls are you seeing predominantly in your role with ComMed? What kind of calls are you getting sent out to?
So pretty much everything, we have a very high incidence of pedestrians being hit by vehicles. That's very common, and we have multiple of those every day. There are a lot of people that are essentially walking in areas, walking to buses, walking home and that sort of thing. So it is a problem. We have a very high incidence of that. Motor vehicle accidents, speed is definitely an issue. There are areas in the country where, whether it's due to politics or, due to gang-related incidents, there's high incidence of shootings, stabbings, that sort of thing. Just plain medicals, people waking up at 3 a.m. with chest pain, that's also pretty common. I think the biggest challenge, though, is that these people just don't have access, or they just don't have immediate access to the necessary care that they need. And in many cases, these types of incidents can be treated successfully if they're treated quickly, but waiting for an hour, even if you're having a heart attack, is a problem. And that unfortunately happens.
Do you have much, I'm assuming obviously alcohol is probably a big contributor, but do you have a lot of calls for substance abuse in general? I mean, particularly illicit drugs or narcotics, or not so much?
We do. I would say it's probably not at the same level that you guys are seeing it at the moment, but certainly we do see it. We also have a lot of overdoses that are self-inflicted, in terms of attempted suicides, and suicide rates are certainly, I think, higher than we've seen in a while, which is unfortunate. But certainly substance abuse is there. Alcohol is a big problem. Alcohol in youngsters and alcohol with driving is a big problem, and is very often the cause, of these incidents.
Now that you mention it, alcohol in youngsters, there was a story in the past few months about, I don't remember, maybe it was in Durban or somewhere else, but there was some story that came out of South Africa about a group of teenagers went to a bar and ended up in alcohol-induced comas. Am I getting the details correct on that?
I'm not familiar with that one specifically, but we certainly do see those types of incidents.
Yeah, it sounded like it was, I never heard what the actual cause was, but it sounded like it was maybe black market moonshine, somebody was cooking up a brew batch at home, and I'm just wondering, is that, I mean, I've lived in a number of countries where ethanol poisoning is a big problem and it's from homemade alcohol. Do you see much of that, or?
Not something we see very often.
No. Okay. So how do you actually get your calls? How do people contact you? Does the government service ask you to send people out, or they call you directly?
So sometimes that does happen. I think now that we have WhatsApp in the world, I think WhatsApp has really changed, how people operate. So we have lots of community groups and community services that operate in the various communities. The pre-hospital services are generally on those groups, and community leaders or people in the community that are essentially patrollers will put messages onto the group, stating that they've had an incident at this location, they require an ambulance, and then whoever's available, sometimes ourselves, sometimes a government service, sometimes private services, will then respond to that. There are also more formal routes, so for example, we have a 24-hour number, that people will call, and we will then dispatch based on those incoming calls. Or sometimes other services, such as the police service, for example, the South African Police Service, will contact us because they have a suspect that's been injured, or they have a situation where someone's died and they require a declaration of death to be carried out, and we would assist with that.
Wow, that's really interesting. All the different ways that they come to you. So I imagine you're probably subscribed to a number of WhatsApp groups and are just monitoring those regularly, or do they request you specifically?
A number A number would be an understatement. You know, there are so many groups. We really try and prioritize. You know, there are certainly key groups that people tend to make use of, and the community forums tend to use. So we will actually monitor those. We do try and get people to actually call, you know, where there are, you know, serious or sort of time sensitive issues. It's quite difficult to monitor the groups all the time, but there are always services monitoring the groups. You know, but where it is serious, we do say try and call us, and then that's going to be a more guaranteed approach. But I mean, there's generally more, I think, more incidents than people to service the incidents, and that's where, you know, organizations like ourselves come into it. But I mean, certainly not to downplay any of the importance of the private services, because the private services really do play a massive role in treating, you know, non-medical aid type patients as well. Unfortunately, the volumes are big, and it means that someone's going to have to wait, and that's the challenge.
So stepping back a little, you mentioned at the outset that you started during COVID. You've been in operation now 3 years, and
roughly 3 years, yes.
I'm wondering if you could share a little bit more about how you got started and what it took to actually put together, you know, a consistent service. We, you know, a lot of our listeners are folks that are trying to start their own services or in the early days. And so this is really valuable to hear how other people have done it successfully. And so if you could share a little bit more about that, that would be great.
Sure. So I think when we started, you know, COVID was fairly new, and it was literally as simple as seeing that people were not able to get access to oxygen. You know, they were phoning for a service. The services were completely backed up, and literally what they needed oxygen. So we started at that point by actually delivering oxygen. You know, we have been very fortunate to have some really great sponsors, you know, who actually sponsor us oxygen, and that also started through COVID. You know, because we had a limited number of oxygen bottles, and we were filling these multiple times a day, you know, and using them and filling them, using them, filling them. What we found in speaking to people was that they really needed more than that in the broader community. And, you know, many of the families that we service, family members are unemployed. You know, for them to get a service to come out, you know, they can barely put food on the table. So their priority is feeding their family. And often people would get ill and they would simply just kind of suck it up, I guess, you know, as opposed to trying to get to a clinic or trying to get to a hospital to actually get treatment. And in many cases, you know, it was not serious issues, or, you know, it may be an asthmatic, for example, you know, things that could actually be treated. And people weren't being treated, and they were getting more ill and eventually dying. And that's really where we saw that gap was, you know, people that absolutely cannot afford medical services or cannot afford to pay for the transport to get to a hospital. You know, and in many cases, these are also areas that the private services often don't like to go into. We also don't like to go into them at times, and at times we need to go in with police escorts. Because they just are dangerous areas, you know, and there are incidents of ambulances being hijacked in South Africa, for example, or ambulance crews being held up, you know, and money and wallets and cell phones and you know, that sort of thing being stolen, you know, which is also very unfortunate, and makes it hard on the services to be able to support people in those areas. But nevertheless, people in those areas require service, you know, and we really can't, from a humanity perspective, we can't just say we don't service them. You know, so we try and work together with security companies who also play quite an important role, you know, and where we can, we'll go in and support these guys, support the families, you know, treat them. In some cases, it's as simple as being able to dress a wound, you know, where they just don't have clean dressings. So we'll dress the wounds, you know, and hopefully they will try and keep it clean or get to to one of the sort of community clinics. We just found that the service just started, the demand just started growing. You know, people were talking to people who were talking to people, and we started getting calls coming in, you know, from all kinds of people, often outside of our area, which makes it difficult because we have a certain sort of area or radius that we operate in. It doesn't make sense for us to be traveling 20 kilometers to an incident. It just takes too long. So we try and work within a sort of 15-kilometer radius, depending on time of day and traffic and so forth, for it really to be worthwhile from an emergency perspective. But that being said, we will often go out to old age homes, or to folk that are on home oxygen to check up on them, just to get a set of vitals and see that they're okay. Perhaps family will often call us to say, do you think our grandmother needs to go to hospital? This is what's happening. Can we check vitals and so forth? So it's very much a dual service in terms of just supporting the community with simple things like that. And the other side is really the pre-hospital emergency medicine side, which is emergency situations. I think from a growing perspective, it's just lots of hard work and lots of hours. It's always a balance. We all have families, we all have day jobs as such, or we work for other services where we work in a shift type environment. So it's really fitting it in between that and ensuring that we have, someone always available to answer the phone, someone available to either go out or where we can pass it on to another service to actually service a patient. And I guess that's where Beacon really started to play a role as well, because as part of this, at a point we needed to make a decision to register under the Department of Health, the South African Department of Health, and that's essentially the government department that registers all emergency services. They maintain the standards, they define, what a vehicle needs to look like, what needs to be on the vehicle, what you need to have in your jump bag, etc. They really govern that, and we made the decision to register under them, which we needed to do. And as part of that, we also needed to have in place a mechanism to be able to manage and track incidents, to report back to them, to look at trends ourselves, to measure things like response times, for example, and so forth. And really that's where I think Beacon has really been a fantastic platform to support us in doing that. And today all our calls go into Beacon, and it really allows us to not worry about the call management side of it, and to not worry about trip sheets and things like that, and to focus on what we do, which is treat our patients, and the rest of it happens in the background.
That's fantastic, and it's a real pleasure to be able to serve you and know that it is of use. You kind of answered this question for me already, but in terms of government recognition and legitimacy, it sounds like you'd mentioned that there are standards that have to be met. What about the training side of it? What level of training do you require for your volunteers to participate? Does it go all the way down to first aider, or do you have a minimum set in order for them to join?
So we actually, from a ComMed perspective, we require that you are a basic life support medic or above. We do have a small number of what we term level 3 first aiders or advanced first responders that are part of the team. They will work very closely with the registered medics. They cannot operate by themselves, but they work with us. They really support us. They're also quite a key part of the team, but they don't run response by themselves.
Makes sense. Absolutely. So you mentioned in a radius of about 15 kilometers. Is that correct?
It's more or less 15 to 18. It depends. If it's at night, or early as the morning, there's not a lot of traffic. We can obviously get further more quickly. Peak hour traffic, 5 p.m. in the afternoon, 5 kilometers is can be difficult. And we kind of tie this in with the current load shedding issues that we have with electricity in South Africa, where there's the rolling blackouts, which means that traffic lights are often not functional, so traffic is backed up, and even with lights and sirens, it can make it very difficult to get to where you need to be quickly.
Very dangerous too. I mean, you don't know what's coming. So what are the future plans for ComMed? Is it you know, a lot of groups, and understandably so, will say, this is our territory, this is where we're staying, and we're going to do everything we can to improve within this area. And others have bigger ambitions, you know, they want to scale. But it sounds, you know, like you've mentioned, there are a number of volunteer groups that are out there kind of filling in the gaps. Where do you see ComMed's place in this? Staying where you are, or do you have plans to expand it all?
So we are one of the very few, if not the only, registered volunteer groups, pre-hospital medicine groups doing what we do, certainly in the area that we're in. You know, we want to keep doing this. You know, people often ask us, you know, do you want to become a paying service at some point? And, you know, do you guys want to make money out of it? And, you know, do you want a fleet of ambulances and so forth? That's not what we want to do. We really are here for the community. We will always do this at no cost. As long as we get sponsorship in, you know, and we have fuel in our vehicles, we will keep doing this. The need is just growing. If you have a look at the demographics and, you know, population growth over the next 5 years in the regions that we're in, they're just huge. You know, and the problems that we have now are not going to get any easier. They're going to get bigger. You know, so I think there's going to be more need for organizations like ourselves. We are certainly always on the lookout for medics. You know, if at some point someone decides to come along and throw a lot of money at us, then we, you know, would certainly be interested in operating an ambulance or 2 or 3. But again, with the same principles. You know, it's not going to be a paying service. It will be a service for the community for people that cannot afford it. And what they don't need to worry about is paying a bill. You know, they don't need to worry about what drugs get used or, you know, what consumables get used. It's really about ensuring that they get the pre-hospital service, emergency service that they need.
Do you ever get concerned about the role that people, or the possibility that people who can pay are avoiding services because they might come to you knowing they don't have to pay? Just to play the devil's advocate here.
Absolutely. Look, it definitely is a concern, and you know, we will service anyone. We absolutely do service people that can pay and people that have medical aid. You know, because we're close by or we can respond quickly. You know, we'll service them and then hand them over to a private service. You know, who will then transport them to hospital. So at the end of the day, it's for us. It's about the patient. You know, it doesn't matter whether, you know, black or white, whatever language you speak, whatever job you have, whether you're employed or unemployed, whether you live in a great area or you live, you know, in an informal settlement, you know, that has no running water and no electricity, it doesn't matter. You know, at the end of the day, it's about being able to service that sector of the population. You know, and every patient that we service, especially those who can afford it, we hope that they go out and spread the word. You know, we have a lot of private individuals that on a monthly basis make donations. You know, and at the end of the day, every rand or every dollar helps. You know, and it all goes straight into the patients. You know, none of us earn any salaries or anything out of what gets donated. It goes right back into procuring stock and, you know, keeping vehicles on the road and so forth. And that's what we do.
Well, that's a real commitment to your calling. You know, and the day jobs that your volunteer works, are they predominantly working as paramedics on for other paid services, or is it a mix of?
It's a mix.
Yeah, that makes sense.
It's definitely a mix.
That's fantastic. It's really awesome.
I think you know, I think what's important, and probably why we work well with all the other services, is that we're not actually treading on anyone else's toes. You know, we're not taking anyone else's business away, or, you know, because of us they're earning less. You know, we are there to just support, and the services that would still, you know, transport patients, whether it's a private or a government or non-paying service, they would still do the same thing. It really just gives them a bit of buffer time, and I think because of that, we, you know, it's important to us to build up good relationships with the other services in the area, because we support them and they support us. You know, and I think EMS is a fairly small community, and, you know, people know people, you know people, and that's kind of how it works. And sure, there's a lot of politics, you know, as there always is, But from a ComMed perspective, we stay out of the politics and we work with anyone, support anyone. We don't affiliate ourselves with any one particular service. We at the end of the day, we're about the patient, not about the services around us.
That's really, really impressive and inspiring work you're doing. I guess one last question I would have is, for other groups that aspire to do what you do, what kind of advice, if you knew then what you know now in terms of getting this up and running, what would you have done differently, or what advice would you give to groups that are trying to kind of follow in your footsteps, follow your path, and launch a similar service?
It's a good question. I think when organizations like ourselves start out, we often start out with not the right level of governance and structure and formality. And that happens because it's, friends get together or colleagues get together, you start doing something and you think, when we grow and we get bigger, we'll start to bring that stuff in. I think it's important to bring a lot of that stuff in right in the beginning, because that structure really sets you up for growth, as opposed to growing and then trying to bring the structure back in is always very difficult. The other thing I would say is people not to give up. There's days that we think, is it worth it? It's not great. Whether it's that you've had a whole lot of bad scenes, or whether it's that we tight on cash, whatever it might be. The next patient that you treat, that looks at you and says thank you. That's what it's about, and that's kind of why we do it, and that's why we'll keep doing it in the way that we do it today.
I think those are two great points. If I could just dig a little bit deeper in terms of the structure, what specifically would you recommend that they pay attention to? I mean, is it the legality, like having, I don't know how big of an issue it is for you in South Africa, but in the United States, litigation is on the forefront of everybody's mind all the time. So is it the legal aspects, or is it just, assigning shifts, or having, an organizational chart? Someone's the treasurer, someone's the secretary, someone's the, taking minutes. What could you say more about the structure that you were mentioning?
Sure. So that's quite a big topic, because you have to have specific roles in place. I think that's important. When we started out, we had this view that it was a team. Everyone would be part of every decision, and that's great until it's not, and at a point it wasn't, so we lost some members, we've had new members join, but it's important to be very clear on what the organization's goals and objectives are, and to stick to those, and to make sure that the people that you're getting into the organization are like-minded. There's lots of people out there that want to be able to, drive a vehicle that has red lights on. That's not why we do it. So we really need people that are patient-focused, that want to make a difference in people's lives and in their communities. And I think if you get the right kind of people in, it certainly makes it a lot easier. From a governance perspective, we don't have the same level of litigation currently that I think you guys have in the US, but certainly it's there. It's certainly there, and we have professional bodies that manage us as medics and paramedics, manage our scope, so one has to ensure that you're practicing within your scope, that you are following protocols, that you are treating patients in the right way, and that when someone comes back to you a year down the line, that you've got the paperwork to show it, and often as organizations start out, people want to help. They don't think about the paperwork side of things. They don't think about possible knock-on effect, and that's an issue. It's an issue for the patients, and it's an issue for the medics as well. So it's important to get the basics right, and it doesn't matter whether you have 3 medics or 50 medics. Make sure that you've got the structure. Make sure that you've got the governance. That the paperwork gets done, that the filing gets done, that you have the right insurances in place, and things like that. All of that's important, and it just makes it easier to do it from scratch.
Probably the least sexy part of the job, but it's so critical. The paperwork really matters.
Paperwork,
so that's a point well taken. Well, thank you very much, Neil. It's been a real pleasure, and it's just awesome work you're doing, truly inspiring, and I'm sure our listeners will enjoy hearing more about it too, and hopefully take some good notes from it, because in 3 years, you've grown quite a bit and are truly bringing a real value to your community. So thank you for your work, and thank you for joining us today.
Thank you. And thanks again for the support that we get from Beacon. We really appreciate it.
Absolutely. And if people want to reach out to you, what's the best way for them to get in touch?
Probably the best is going to be info@commed.org.za. org.za.
We will add that in the show notes and put it on the website as well. Thank you, Neil.
It'll be great. Thank you. Take care.